15 French to 17 French or 19 French at the maximum with the dilators. These are various arterial cannulas from the biomedicus, and they have got some biomedicus cannula are not radiopaque in the terminal portion. They have got a radiopaque marker at the tip. So this tip marker is a guidance that where is the tip of the cannula. Then the number of holes and the M number and the French size number are different in different companies. The M number is a ratio of the size of the cannula and the amount of fluid pressure it requires to be wasted by passing the cannula through it. So this is the French gauge. In French gauge, it ranges from 6 French to 52 French size cannulas. There is a conversion factor from millimeter to French. A 0.33 millimeter is equal to 1 French, or 1 millimeter is equal to 3 French. Then in cannula, for a venous cannula, you waste around 20 mm of energy pressure drop. For an arterial cannula, you waste around 100 mm in a G of pressure drop. So therefore, in other ways, according to the formulas, this is already covered by OJA in terms of the body weight. Around 100 ml per kg body weight is the required flow required, and so are the sizes of the arterial cannula. These are the sizes of the venous cannulas, and according to the weight of the patient and the amount of flow required, you have to select the size of the cannula. Then for a pediatric population in double lumen cannula, there's a range between 12 French to 15 to 18 French, and according to the age, approximately the drainage cannula and the return cannula are sized according to the weight and the amount of flow required. So we always try to aim for the biggest possible. As I said, the size matter. If it is snugly fitting, you get better flows. The cannula design can again be divided according to the wall thickness. If it is a thin lumen cannula, that requires a greater flow, that allows a greater flow. These are the cannulation sites, the arterial sites and the venous site. So from aorta to axillary artery and to femoral artery are the arterial sites, and the venous site from right internal jugular vein to left atrium, and all of the femoral veins and the pulmonary veins, they are all sites of venous cannulation. So the cannulation can be of two types, the peripheral and the central cannulation. The central cannulation, they provide drainage from right atrium or the aortic route or the pulmonary venous flows. And the advantage is that it requires a minimal additional dissection. There's a good drainage, it improves the coronary circulation, it increases the venting options. And the disadvantage is that the cannula may dislodge, it can cause bleeding, and it can cause a depressed respiratory function. The peripheral venous cannulation, the vessel required are all peripheral vessels. And who should cannulate? The VV ECMO is less demanding. The most staff should be appropriately trained, and complications are infrequent, but they do happen. The technique again depends upon Seldinger, semi-Seldinger or open technique. Now the procedure for patient preparation, you may have to require anesthesia or analgesics. Anesthesia may be ketamine, etraquirine or heparin. And the semi-Seldinger technique, the apparatus is the same. For venous cannula, for a neonates, the French sizes are 12, 15 and 18 French. Double lumen cannula is done through right internal jugular vein. And this is the dissection for an adult patient. And this is the venous cannula, the double lumen, and the dilators, the wires and the cannula. You try to take a dissection of around 1 to 2 centimeters above the suprasternal notch. And this is a semi-Seldinger technique. You expose the internal jugular vein, take the controls, and then you decide the size. It is around 7.5 centimeter from that distance, roughly 7.5 centimeter from the skin. By the time you reach the SVC-RA junction, and you have the same procedure as we do for an open cannulation. You incise, you dilate, you insert the guide wire, and then progressively dilate, and then check for the blood coming freely and give heparin. And these are just the surgical slides to show you how do we do the puncture. This is common, this is very familiar to everyone. Double lumen cannula. The double lumen cannula, you can see the aspect ratio. The venous cannula takes 2/3 of the lumen, the arterial cannula 1/3 of the lumen. Then Seldinger technique, again, ultrasound guidance, fluoroscopy guidance, the positioning of the cannula, then the Avalon cannula. The Avalon cannula comes in the French size is on 13 French to 31 French. This is the Avalon cannula. There are 3 ports, the SVC port, the IVC port, and the tricuspid valve return cannula. The return cannula faces medially towards the tricuspid valve, and the blood goes directly into the tricuspid valve, whereas the drainage is from the SVC and the IVC drainage cannulas are there. So this is just a picturization. This is taking securization. Now very well, this is just to show you the layout, that after securing, you have to make the tube in a way that there is no kinking, and that is how you stabilize them on the patient. Now the femoral cannulation, in femoral cannulation, you, by Seldinger technique, these are the fixation points at various, after taking the position, and this is the radiological appearance of the cannula. This is the arterial cannula, this is the venous cannula, and there can be more cannula, venous cannula, to prevent recirculation. So there can be a SVC and a femoral vein cannula, and a return cannula can be in the IVC. So now a veno-arterial cannulation for a pediatric and an open procedure, that requires a lot of precision and expertise, and because even 1 millimeter, I would say 5 millimeter displacement is sufficient to cause a lot of havoc in the total circulation. So the procedure is the same. This is just to show you the neat and a clean dissection. So this is a rough dissection of around on the medial border of the sternocleidomastoid, and you fix the fixators. That incision is around 1.5 to 2 centimeter above, and this is after applying the clamps. This is the prominent structure. You see the interjugular vein, then the carotid artery medially, and this is a single loop and a double loop clamps to make the exposure wider. And then you take the controls. After taking the controls, you take the arterial cannula. The arterial cannula has a distance of around 2.5 to 3 centimeter from the point of incision on the artery, and you ligate the distal tie on the carotid artery, and this is how you take a position and introduce the cannula. Then for the, this is all the picture. This is how you take the, secure the cannula. The cannula is secured over a rubber piece, so that it does not cause damage to the vessel, and then take a secure second tie over the rubber piece again. So then you tie both the pieces of the rubber. Then this is to connect the cannula with the extension tubings, and from the extension tubings then comes the venous cannula. The venous cannula is at a distance around 7.5 centimeter from the point of incision, and this is how you advance it. And the same steps like the arterial cannula, then back to back air to air removal, water to water interface, and then connecting to the extension tubings, and then secure it with the skin. So this is the final position of the VA ECMO. And then for open cannulation, or for the chest cannulation of a cardiac ECMO, this is how to show you the position of the various cannula and the structure it is penetrating. That is the IVC level, that at the right atrium level and the aortic level, and it is a bleeding mess, definitely open cannulation, but this is required post cardiotomy. So a distal perfusion cannula is very important for VA ECMO for ipsilateral limb perfusion, and therefore it is a small introducer sheath. You can do a Gottes graft also to prevent arterial damage. So okay, so this the pictures were just to show you, because I cannot show you arterial or a surgical procedure in this conference. So I just covered it the slides. Now try to find out what is happening. What you see, the radio-opaque part, some cannula, the Medtronic cannula are having 4 centimeter of non-radio-opaque part which goes lower down. So to keep that in mind. So now this is the position of the double lumen cannula. This is the radio-opaque, this is the X-ray picture, but the cannula tip would be somewhere up till this point. Okay, again this is the same thing to show you the position of the single stage cannula. This is the position of the cannula after the radio-opaque part. Okay, can you identify the problem? What is the problem? The arterial cannula has gone up here. So the arterial cannula is too high, The arterial cannula is too low, and both the cannulas are too low in this position. So an X-ray would tell you all these things after the, before taking the sutures. If you can take an X-ray, you can position the cannula properly. The complications of ECMO can be bleeding, infection, cannula malposition, pneumothorax and vascular injury. And all these things I would just postpone. This thing we have show it every time, though most of us never get a chance to put an Avalon cannula. So let us see it in pictures. How much time, Pooja? I'm getting late, or I can continue. 11:10. 5 minutes. Nothing new in that. Only thing is just to show you about the dilatation part. This was a percutaneous insertion, a very less blood loss. Remember, if you do a semi-Seldinger technique or open technique, you will require at least 1 unit of blood each day to compensate for the blood loss oozing from the incision site. Whereas if it's an open VA cannulation, this is just taking the controls, opening the site. This is just to show you the IVC position of the cannula in the IVC. This is to show you the distal perfusion cannula being inserted. finally it becomes a bigger procedure if it's an open cannula technique. So my advice is that if possible, most of the ECMO program should be under an intensivist in any hospital, because they supervise the whole case from beginning till the end. And similarly, if they are the ECMO specialists, then they should know every procedure. So ECMO specialist or intensivist should be the first operator for each cannulation, because that is going to make the difference in outcome in a bad patient. And thirdly, the steps, I would always suggest that you take all the punctures first. I will again show you during the procedure, but suppose if you are doing a VA ECMO and you are taking a femoral artery puncture or a groin puncture, you take 3 wires, 1 wire for the interjugular vein, 1 wire for the femoral artery, the 1 wire for the femoral vein, 1 wire for the femoral artery, and the 3rd wire for the ipsilateral antegrade puncture for the distal limb perfusion. Take all the 3 punctures before doing any dilatation. Put all the 3 wires inside. As you put the first wire, give heparin. After giving heparin, you start first dilate the vein, because vein is a better tolerant structure. So you put the venous catheter all the way along, and then keep the venous cannula open so that you see the column of the blood moving. That will prevent clotting of the blood inside the cannula. And you keep on dancing the cannula at a degree of 30 to 40 degrees, so the blood keeps on moving. In the meantime, you take the second puncture, the dilatation of the femoral artery, and you have after dilated the femoral artery, then put the cannula also into the femoral artery. Both the cannulas are in place, connected to the ECMO circuit. Once the ECMO circuit is in flow and you achieve a stability in the patient, over the 3rd wire, which was already put in the antegrade direction in the ipsilateral femoral artery, then you part the distal limb perfusion cannula and then connect it to the lever lock or the side port of the arterial cannula and start perfusing the distal limb, the antegrade distal limb accordingly. So 3 cannulas, 3 wires, all 3 wires first to go. Take proper punctures. The distal limb perfusion puncture is above the inguinal crease, so we puncture it antegradely slightly above the punctures of the femoral vein and the femoral artery. After all 3 wires in place, after the first wire, give heparin, then dilate the femoral vein, then the femoral artery, connect it to the ECMO, stabilize the patient, then take the distal limb perfusion and introduce a sheath and connect it to the arterial cannula. These are the steps for cannulation of any patient in a VA ECMO. And that's all. Shortage of time, we'll sort of demonstrate you how to do a puncture, what you'll be doing there. So we'll start with the practical demonstration. Of course, you have to position it, you have to, again, of course, once the cannula is in place and the flow starts, you have to see the flow of the returning blood directly entering into the tricuspid valve. Or it may roll on the wall of the right atrium, but it should divert it towards the tricuspid valve. So you have to turn and rotate the catheter and see adequate flow of the jet of the blood returning into the tricuspid valve. That is very important. And as you rotate, you keep the arterial end at 12 o'clock position or 2 o'clock position. That is an external guidance. Yes, very important, because this is the best site. No bones here. So Ziffy sternum is very helpful for a ultrasound or a ECMO specialist or a cardiologist to see where the catheter is, what is the lumen, is the flow coming or not, any clot, anything. So this is always a very helpful site. It is relatively very good pictures are seen from Ziffy sternum. You may not find things the same way in the iliac vessels, but Ziffy sternum is a very good site.
For VV ECMO, the double lumen IGV cannulation is better, or the VV femoral cannulation, you think?
If it
as
is
a technical or logistics, whatever it may be.
Very obese patient, around 100 kgs, single stage cannula would be required because high flows will be required. A medium age patient, 70 kg, 60 kg, you can have a double lumen VV ECMO cannula.
What happens if the flow is not directing to the tricuspid wall, the returning flow?
There is no reason. Of course, what happens, there is an answer. What happens, the IVC to RA junction is an angle of 30 degree, and the IVC to RA junction is another angle of 30 degree. So the cannula is in fact not straight. It is a tilted course from SVC to RA and IVC to RA. It is not a straight course. So once you position the cannula, you find the cannula is stuck and it is not rotating. It happens. But if you find with whatever maneuver, ultimately taking a curvilinear course also, if the middle orifice is directing the entire flow, that you see very forceful flow. The color flows on ultrasound are very good because the entire cardiac output is returning, ECMO flow from the ECMO is returning from the middle port. So the color flows are very good there. You have to see ultimately it directs into the tricuspid valve.
Okay.
Right. If it is a difficult course because I said that SVCRA will push it into the right atrium and towards the right ventricle. Again, it has to go back to IVC, which is at an angulation. So sometimes maneuverability by itself, by luck or hook or crook, it goes. You may try it for a few times. If it does not go, you can take a right coronary diagnostic catheter, put it over the wire. That has got a angle tip, and that will direct the catheter towards the infra-posterior part of the right atrium. From there, the wire will go into the IVC. Yes. No, with ultrasound also, you can see the catheter. If the patient cannot be taken to cath lab, by ultrasound also it helps. You can see the wire is radio opaque. The catheter is almost having a shadow. You can direct it that way.
So for a single lumen catheter, where should be the position of the guide wire in the IGV?
You have to cross the distal parking place. If it is from the femoral vein, you have to cross the right atrium. So the wire has to be in the right atrium or higher in the right atrium, so that you know there is no obstruction anywhere. Then you start dilating. Then you put the cannula. The cannula, if it is tipped radio opaque till the tip, you have to reach at the IVC RA junction. Or sometime if you find there is a recirculation, you may pull it back into the hepatic IVC. Sometimes if the tip is not radio opaque, there is 4 centimeter of only plastic cannula, then you have to pull it slightly lower down. So you have to see your cannula and then see the radiology part.
For single lumen cannulas, how can we confirm the position of the arterial and venous cannula on X-ray, sir? Ideal position of cannulation on X-ray.
As I said, the venous cannula, nowadays people practice to put the cannula 1 or 2 centimeter in the RA. Otherwise, we used to practice at IVC RA junction to see it does not causes arrhythmias. So if your radio opaque part is to the tip of the cannula, and you position the cannula, and then you take an X-ray, if you find the position of the cannula is above or below, you have to pull that much part, take another X-ray, or the best thing is to do ultrasound. For arterial cannula also, difficult to do on see the things very clearly on ultrasound, but on X-ray you can see very well. Anyway, the arterial cannula has to remain in the iliacs. It cannot come at aortic bifurcation. So if you are 1 centimeter below in the common iliac also, doesn't make a difference. But you have not to cross the aortic bifurcation.
Is there a role of transesophageal echo for the cannula position?
Yes, there is a role, but I am afraid about bleeding. Any abrasion on the vessel wall of the esophagus will create a mess. So as far as possible, I tend to remain less invasive and non-traumatic and induce less infection. So if not required, if I am getting things solved by skin ultrasound, or I would not like to go for transesophageal.
How do you measure the length of the return cannula externally, sir? Whether we need to check the pricking point to manubrium sternum, any other reference point, sir?
Return cannula, SVC RA junction. So yeah, roughly we position it in an adult around 15 centimeter, in a pediatric around 7, 8, 9 centimeter, depending upon the length of the children or the child. So therefore, again, what is the exact point of SVC to RA junction? Not very clear. Even if you are 1 centimeter in the RA, does not make a difference. You will get a better return.
Only usually on X-ray we see at bifurcation level. Bifurcation of trachea, we just see the cannula. That should be fine.
Thank you, sir.
Regarding the femoral artery cannulation, do you use per closure pro-glide stitches, sir?
No, in fact, that our artery cannula is usually 19 to 21 French, okay, or 17 French. So that per closer, that's still not a good idea. There are some centers who have started doing it, but the issues can be, one is risk of aneurysm. Second is it may not close completely. Third is there during this run there might you have a distal perfusion cannula also. The distance between the distal perfusion cannula and your cannula, there might be a chances that there can be a clot formation there. So if you are using percutaneous percloser, then probably you will not able to remove that clot. So usually practice is we surgically remove it, and when we are before removing it, we do a Fogarty also, so that we can take out what are the clots are there inside. So usually we don't recommend for ECMO use at least.
And all these things, there is a sloughing of the vessel over a long number of days as you do a tie-up, or so therefore if you use a percloser, it may be dealing with a damaged portion of the artery, so there are chances of bleeding.
Sir, so you mean to say that perclose, what they use, it's only for a few, like limited duration?
Yes,
like
that is only for 4 hours or 2 hours for a TAVR procedure or something like that, where vessel integrity is maintained. But if you try to use it for a ECMO, which is already lasting for more than 7-8 days, the vessel edges would be sloughed. So I'd strongly not recommend it.
Thank you.
See, as of now, sir, if you talk about, I talk about my centers, we have done more than 400 cases, and never ever we have called a surgeon. It does not mean that there have been not accidents, but if arterial cannula, as said, is 17, 19 lumen, and we are very much mindful about ultrasound. So at least in arterial part, we did not have any problems. But as you are starting to beginning a ECMO program, you have to have escape mechanism or a backup mechanism. So you may do it as a first operator, but you should call a cardiac surgeon as a standby for few cases. What size, what age?
Usually, neonates usually used to go by a the open technique or semi-selling technique.
Femoral
not,
vessels till 2 years of age, Dr. Pupani will correct me, that they are not an option at all. They will go into spasm and amputation is the only ending point. So femoral vessels, not an option for neonates. So anything you want to say?
Semi-selling. Cut down and selling. Yeah. But again, ultrasound will be useful for you.